Hi, I'm Igor, and today we will go talk about immunoglobulin A vasculitis, or also known as Schonlein purpura or Anaphylactoid purpura. Immunoglobulin A vasculitis, previously referred to as Henoch Schonlein purpura, is an acute immune complex-mediated small vessel vasculitis that most commonly occur in children. Epidemiology: sex more in men than women, age more common in children, and 90% of affected individuals is less than 10 years. Peak incidence is 6 years. Pathophysiology is based on hypothesis of pathophysiological mechanism is exposure to allergen or antigen, for example, infection, drugs, which leads to stimulation of immunoglobulin A production and deposition of immunoglobulin A immune complex in vascular walls. In the skin, GI tract, joints, and kidneys, activation of complements and leads to vascular inflammation and damage. The exact pathogenesis is unknown and assumed to be multifactorial. Factors that likely play a role include preceding infection up to 90% of cases and preceded by viral or bacterial infection 1 to 3 weeks prior. Most commonly an upper respiratory tract infection caused by group A streptococcus and GI infection also possible. Many other organisms have also been associated with immunoglobulin A vasculitis, immunoglobulin A nephropathy, drugs, ACE inhibitors, clarithromycin, and vaccines, genetic predisposition, and solid organ malignancies in adults. Clinical features: an upper respiratory tract infection often precedes symptoms onset by 1 to 3 weeks. Constitutional symptoms is low-grade fever, malaise, and fatigue. Skin: symmetrically distributed erythematous papules or urticarial lesions that coalesce into palpable purpura. Bullae, pustules, and necrotic or hemorrhagic purpura more common in adults. Most commonly in lower extremities, buttocks, and other areas of pressure are constrained, for example, from clothing. Is symmetric purpura lesion in a patient who suffer from Schonlein disease. Biopsy of the kidney and immunofluorescence of the kidney in patient with Schonlein disease. Children who suffer from rash in patient with Schonlein disease. Clinical features include joint changes is arthritis, arthralgia, most commonly in the ankle and knees. Gastrointestinal tract is symptoms like colic abdominal pain, intussusception, hematochezia or melena, and nausea and or vomiting. Kidney immunoglobulin A vasculitis is nephritic syndrome. Other organs is rare, but can also include in these symptoms is epididymoarthritis, urethritis, central and peripheral nervous systems, headache, seizure, intracerebral hemorrhage, and respiratory tract. Mild intestinal changes, alveolar hemorrhage. Eyes is episcleritis and uveitis. Immunoglobulin A vasculitis characterized by PAPAH is purpura, abdominal pain, arthritis, arthralgia, and hematuria. Immunoglobulin A vasculitis is much less common but typically more severe, involving hemorrhagic or nephrotic skin lesion, immunoglobulin A nephritis in adults than in children. Immunoglobulin A vasculitis is an important differential diagnosis to consider in children with a limb. Pediatric and adult patient. May a clinical diagnosis of immunoglobulin A vasculitis based on typical clinical features, obtain laboratory studies to identify organ involvement and exclude alternative diagnosis. If the diagnosis remains unclear, confirmatory biopsy. Suspected immunoglobulin A vasculitis in any patient with palpable purpura arthralgia, and abdominal pain. Laboratory studies include CBC, usual normal platelet count, and decreased hemoglobin suggest gastrointestinal bleeding. Basal metabolic panel, increased creatinine and or blood urea nitrogen suggests immunoglobulin A nephritis. Coagulation panel, typical normal. Urine may be normal. Abnormal values suggest immunoglobulin A nephritis. Urinalysis, first sample of the day, hematuria, proteinuria, microscopy is nephritic sediment, red blood cell cast, dysmorphic red blood cells, stool blood test positive if there is GI bleeding. The following studies may support the diagnosis of immunoglobulin A vasculitis but are not required in the diagnostic workup. Is increased erythrocyte sedimentation rate, C-reactive peptide, if preceding streptococcal infection, hypocomplementemia, antistreptolysin O is increased, and immunoglobulin A in the serum. Imaging studies should be obtained according to the patient's symptoms and/or suspected complication. Abdominal ultrasound indicated in patients with abdominal pain to evaluate for intussusception. Intussusception is the most common complication of immunoglobulin A vasculitis requires surgery in children. Biopsy. Biopsy is done histology from the skin and or kidney confirms the diagnosis of immunoglobulin A vasculitis. Skin is indication a typical skin feature finding leukocytoclastic vasculitis, immunoglobulin A, and C3 complex deposition hallmark in small vessel of the superficial dermal skin day. Indication is severe renal involvement. Findings: mesangial immunoglobulin A deposition, C3, and fibrin. Crescent formation in most severe cases. Treatment is decisions about pharmacotherapy are based on symptom severity and should be guided by a specialist. All patients provide supportive care, ensure adequate hydration, and which include oral rehydration therapy and intravenous fluid therapy as needed, provide NSAIDs and/or acetaminophen for pain, discontinue drugs suspected of inducing immunoglobulin A vasculitis, and patient with severe vasculitis and/or immunoglobulin A vasculitis nephritis initiates systemic glucocorticoid therapy. More cases of immunoglobulin A vasculitis are self-limited and only require supportive care. Systemic glucocorticoids indication is immunoglobulin A vasculitis, nephritis, severe abdominal pain, rectal bleeding, orchitis, cerebral vasculitis, pulmonary hemorrhage, other feature of severe vasculitis. Disposition. All patients require scheduled outpatient follow-up to monitor for delayed renal impairment. Renal complication. Immunoglobulin A vasculitis nephritis may progress to nephrotic syndrome. Serious complication, rapid progressive glomerulonephritis with crescent formation. End-stage renal disease. Gastrointestinal is intussusception and small bowel infarction or perforation. Follow-up. Patients with immunoglobulin A require follow-up due to increased risk of chronic kidney disease. Monitoring blood pressure, urine studies, urinalysis, urine protein to creatinine ratio, urine albumin to creatinine ratio, serology, serum with creatinine with estimated glomerular filtration rate. Prognosis is good. Immunoglobulin A vasculitis resolved with full recovery. However, relapses is likely in patients with previous renal involvement. Thank you. Subscribe to the channel.